I said we didn't expand it. Why you expand it? Okay, leave it. No, take this because it doesn't work. Assalamu alaikum. Thank you for this nice introduction, and I thank the organizing committee to invite me to give this talk. I hope it will be interesting, and I will not bore you with a lot of information. So I think this topic is of mutual interest to physicians and clinical pharmacists. I think most of the audience is pharmacists, so it will be, inshallah, very clinically practical. So the objectives of my presentation, it will be overview of the current anticoagulants in the ambulatory care setting, describe the clinical monitoring of current anticoagulant, and it will be the outline of my presentation. It's worth to mention the grading recommendations of the antithrombotic and thrombolytic therapy 8th edition of ACCP guidelines, because I will use it in my slides many times. And what's warfarin? Quickly, what affects warfarin? Key points about monitoring warfarin therapy, common misconceptions of patients about warfarin, low molecular weight heparin, and monitoring new anticoagulants and monitoring. At the end will be conclusion. So this is the common reference for all people interested in thrombosis, and it will be it has so many chapters, and the most applicable chapter here is the pharmacology and management of vitamin K antagonist, and it will be cited in my presentation many times. And so regarding the grading, that's very important. You know, we have a grading system, 1, which means strong recommendation, and 2, weak recommendation in brief, and A, B, C, which indicating the quality of evidence. Like if you have A, you have RCT and observational study with very large effect, and regarding B, it's downgraded RCTs or upgraded observational studies, and C, the least quality about observational studies and RCTs. So we will speak the common language, so because it will be mentioned in the whole slides. And this is just a snapshot of the thromboembolic diseases divided into arterial and venous diseases. And regarding the venous disease, DVT and BE, which is called venous thromboembolism, arterial thrombosis, stroke, heart, acute coronary syndrome, and peripheral arterial disease. Regarding the indication of anticoagulant therapy, it's used in wide spectrum of diseases, but the most common indication is atrial fibrillation. And this is, if you have any venous thromboembolism, this is the treatment pathway. You have to initiate treatment with low molecular weight heparin or fondaparinux or unfractionated heparin for 5 to 7 days till you ensure the warfarin gets into the therapeutic range. And duration, it will be variable according to the indication. But it is a must to start some sort of heparin. And it will be mentioned in my next slide. And this is just some historical perspective of warfarin. If you notice that warfarin, been introduced into the clinical use in 1950, and since that time it's still been used commonly. And it was interesting, story. It was discovered, we call by serendipity. Serendipity, it's by chance, but it's not any chance. It's, we call definition of serendipity, it's fortunate discovery of new information. And then low molecular heparin introduced since for the past 30 years, 1980, and we have now the new anticoagulant. And this is just the story that of discovery of heparin and warfarin. It was the sweet clover problem. So by chance they noticed that the cattle consuming this plant, sweet clover, started to have hemorrhagic disease of the cattle. Then from that they started to investigate this medication, and was developed as rat poison. But when you give it as rat poison, it is in mega doses, like in 500, okay? And why by serendipity? Because it was the first time, used by human. It was a suicidal attempt. It was unsuccessful suicidal attempt by one of the Navy recruits in the United States, and they found the patient had bleeding, but he did not die. Then they started to use it as anticoagulant therapy. And warfarin, as you know, the name, it is WARF, stands for Wisconsin Alumni Research Foundation, north of the states. And warfarin, it's a vitamin K antagonist, which interfere with the cyclic interversion of vitamin K and vitamin K epoxide, and therefore prevents the gamma carboxylation of glutamic acid residues on the N-terminal regions of vitamin K dependent proteins, and affect two clotting factors 2, 7, 9, 10, protein C and protein S. That's why warfarin has pro-thrombotic effect when used initially. That's why it has to be overlapped with low molecular weight heparin, because warfarin will reduce protein C and protein S by 50%, and particularly in people who have protein S and C deficiency are likely to develop warfarin related skin necrosis. And this is just why the reason I highlighted, the factor 2, the prothrombin, because it's the main clotting factor that we need 5 days to lower this protein. And the main enzyme here, we found that vitamin K epoxide reductase. It's very important to know, because we know the genetic polymorphism affect this vitamin K epoxide reductase enzyme. And the antithrombotic effect of warfarin requires reduction of prothrombin factor 2 and half-life factor 2 60 to 70 hours, which takes average 5 days of warfarin treatment. And INR initially reflects reduction in factor 7, half-life 6 hours, which takes 2 days of warfarin. Sometimes we found when we initiate warfarin, rise of INR, but this does not reflect the true effect. Just continue the same dose, don't decrease, because it might be the effect of factor 7. And the patient is prothrombotic until INR gets into more than 2. And this was tried in clinical trials. They compare 1.5 to 2 to 3 and came to be 2 to 3 superior to 1.5 to 2. And as you know, it's affected by, it's very, hectic drug, and it is affected by herbs, dietary supplement, and I say just warfarin does not play well with others. And poor nutritional status, age, body surface area, gender, liver disease. So we have to keep in mind when we initiate the dose of warfarin. Because in elderly patient, like more than 75, we should not initiate with high dose. We should start with low dose, 2.5. And it's long list, the medication that interact with warfarin. But what's the clinical implication here? Clinical implication, the most important two medications that we are frequently encounter in our anticoagulation and thrombosis clinic, antibiotics and NSAIDs. Yes, the patient can take antibiotics. However, you need to monitor INR after 3 days to make sure the patient might not have any effect, might be supratherapeutic, might be subtherapeutic, depends on the type of antibiotic. Also NSAIDs, if the patient need analgesia, go for paracetamol. If it is mandatory NSAIDs, yes, give the patient, but you have to monitor INR closely. And what affects warfarin? The genetics. It is very intriguing, the discovery of the polymorphism in the genes for cytochrome B450 CYP2C9. And VCOR, which is the vitamin K epoxide reductase complex subunit, have been shown to influence response to warfarin. So warfarin consists of two active apical isomers, R form and S form, which are metabolized by different CYP P450 enzymes. S warfarin is more potent than R warfarin. And just to cut it short, that the mutations in the CYP2C9, if you have this mutation, the patient, there will be increased metabolism. That's why, there will be decreased metabolism. That's why you require a small dose of warfarin. And we have so many patients in our clinic, they are taking warfarin 1 milligram. Sometimes we have one patient 0.5 milligram 3 times per week. So we didn't check for this mutation, but most likely the patient has it. And so the question, what affects warfarin? The genetics, the VCOR, it's the reverse. For these patients, they usually require high dose of warfarin. And some patients we have been following our clinic like 30 milligram. And what does this mean for my patient? This is very important. So currently no implication for clinical practice. The genetic testing is expensive and to date has not been definitely shown to change time to therapeutic INR, time within therapeutic INR or TTR or clinical outcome. And it does not eliminate need for INR monitoring. And there have been, this was published in 2008, okay, and the guidelines, and this is 2009, and there have been only 3 small randomized trials testing this theory, and meta-analysis failed to show clinical benefit, and it is likely this testing will not be cost effective. It seems premature to use this exciting new information until larger ongoing trials are completed. There is ongoing trial which is called COAG, clarification of optimal anticoagulation through genetics. It's still under recruitment and will be completed by 2012. By that we can draw a firm conclusion. And should genetic testing be done prior to initiating warfarin? This is the recommendation. They said at the present time for patients beginning vitamin K antagonist therapy without evidence from randomized trial, we suggest against use of pharmacogenetic-based initial dosing. And what are the key points about monitoring warfarin? Initiation of warfarin, there are a number of published warfarin algorithms available, and just I'm listing down, there are some websites. The first one, warfarindosing.org. This is a free website, and it integrates the genetic testing, CYP2C9 and VCOR. And the other one, it is anticoagulationadvisor.com, and it's available in iPhone, in any personal digital assistant, in Palm, and it is really practical. But it has a fee like $25. And initiation, we always now, previously the people, they used to be generous. They give 10 milligram. Right now, it's the guidelines to give 5 milligram. I mean, 10 milligrams is obsolete. Why? Because if you are, because with the availability of the high quality anticoagulation clinic, I mean, you can discharge the patient on low molecular weight heparin and you give him 5. You don't need to rush to give 10 milligram. 10 milligram, you might have bleeding, you might have warfarin-induced skin necrosis, and you have to keep in mind, particularly in elderly people, should be start with 2.5 milligram. And INR testing should be begin after 2 or 3 doses, and there is no need to do daily INR testing. And in our thrombosis clinic, typically gives 5 milligram daily for 3 days and then check INR unless elderly or high bleeding risk. and no need to give low molecular heparin or heparin concurrently with warfarin if the indication for anticoagulation is atrial fibrillation. You can just immediately start warfarin. Target INR 2 to 3 for most indications. Even because for the sake of time, I did not mention that antiphospholipid syndrome previously was high intensity anticoagulation 2.5 to 3 or 3 to 4. Nowadays, it's been treated with target INR 2.5 and range 2 to 3. And maintenance, if just, this is very practical, like you are following a patient and INR is 3.1, what you should do, just leave it as it is. If just outside of the therapeutic range, a dose change might not be necessary, because this is one of the inherent features of warfarin. It will fluctuate by 0.5, 0.3 every day. Just you might monitor it after 2 weeks, 7 to 14 days, you find it in the therapeutic range. So, but if significantly outside of therapeutic range, and we have to decrease total weekly dose by 10 to 15%. It's not difficult. It's a rule of thumb. Like a patient, I will give you a patient taking 7 milligram once daily, and a patient is sub-therapeutic. What you need to do, you need to add like 10 to 15%. 10 to 15% will be equivalent of 1 day dose to add it to the weekly dose. Like 7 milligram, this is, you will distribute the 7 days. Your patient will be taking 8 milligram. As simple as that, okay? And you have to use dosing normogram just to have a systematic approach. And this is supratherapeutic INR if it is less than, and this, it keeps on changing. We don't know, the guidelines maybe after 2 years might be changed. So you don't need to memorize it. Just keep it, in a note for you. And INR less than 5, no bleeding, lower dose, check INR in 2-3 days. INR more than 5, but less than 9 and no bleeding, omit next 1-2 doses, repeat INR in 1-2 days. Here, some people different approach, they will give low dose, 2 or 2.5 milligram warfarin. Of vitamin K. INR more than 9 and no bleeding, you hold warfarin, give vitamin K 2.5 to 5. We noticed here that people are very aggressive in terms of vitamin K. They give 10. This is not good. Actually, you need just 2.5, okay, to lower the INR to the subtherapeutic range within 24 hours. Because 10 milligram, it might cause resistant re-warfarinization, okay? And subtherapeutic, there are some validated guidelines available, and in general, increase, this has already been mentioned. And this is what we have. We are using normogram. This algorithm was developed by Anticoagulation Clinic of Henry Ford Hospital on the basis of expert clinical, and we have been using this normogram. It's successfully in our clinic, but we don't have comparison pre and post this normogram. It's the same, the one that Henry Ford. Fluctuating INR, the new guidelines, so this is, you have to consider classical causes for fluctuating INR. I'm sure all of you know, but right now, so this is new in 2008, the patients with variable INR be treated with daily low-dose vitamin K. It is 100 to 200 microgram per day. This is to maintain, to ensure, consistent intake of vitamin K. And this is according to the guideline, and this is the trial, okay, based on that they put this recommendation. And regarding anticoagulation management surface strategies, ACCP guidelines for healthcare providers who manage oral anticoagulation therapy, we recommend that they do so in systematic and coordinated fashion like what we are doing, okay? And incorporating patient education, we have made some educational materials, systematic INR testing, tracking, follow-up, and good patient communication. And we just devoted a cell phone for patients who have supratherapeutic INR, who have bleeding. They just text message for us, and we take action for that. And this is high quality anticoagulation clinic. It's been tested, okay, and there are many observational studies that have demonstrated improvement in the time in therapeutic range, which is a well accepted surrogate marker of good anticoagulation clinic. And this is a systematic review of 67 studies that found that time in therapeutic range, it was improved, okay, from 56.7 to 65%. And this is, we have just making some educational materials. This is for tracking INR. This is for, educational material for DVT, because we have to speak the same language with patient. And this is for tracking INR again, and thrombophilia. This is another difficult problem, bridging. So bridging anticoagulation, because most of patients on warfarin, they require surgical intervention in the future. So for this, we have made simplified bridging order. This is translated in Arabic because most patients have confusion once they go for perioperative anticoagulation. And this is also, we have made, it's not showing, we have made also a letter to the dentist. This is not showing here, because always it's common question from dentists to us what we should do. We will have dental extraction, we will have some, root canal. We have made some guidelines they will follow. We just send letter to the dentist and he will follow accordingly. And this is the normogram mentioned already. This is also to have unified duration of anticoagulation for all, across all indications. And this is what about INR patient self-testing or patient self-management. We have started in our clinic the point of care testing INR, and we are not in the phase yet that a patient to have it at home and check INR, then he will call us. And the most advanced stage, the patient will check his INR at home and will dose himself. He will follow the same normogram, okay, we are using. And it's been used in the US and was successful, but you have to be selective for your patient. And this is computerized INR monitoring. And this is, we don't have it here. It's very efficient. It will calculate all the dose for you, next appointment, time in therapeutic range. It will drug-drug interaction. It is very friendly to use. And this is the DON in the States. And we have the...
Dr. Mohammed? Time is up.
Okay.
How many minutes?
Yeah, just 5 minutes. I'm done. Okay. And this is the another one abroad. This is in Europe. And this is the surrogate marker time in therapeutic range. And there is mathematical method to calculate it. And the role of clinical pharmacist in unfortunately, we don't have clinical pharmacists in our anticoagulation clinic, but hopefully in the future we will collaborate them. And they have very significant role. And I did not overview all trials. Okay, and this is low molecular heparin. Everybody knows what is it. Just when you need to monitor low molecular heparin, when we have renal insufficiency, creatinine clearance less than 30, suspected low molecular weight heparin, breakthrough, morbid obesity more than 190, pregnancy. Otherwise, patient, we don't need monitoring of low molecular weight heparin. And if you have if you have a creatinine less than 30, try to avoid low molecular weight heparin. Go for unfractionated heparin. If you use it, adjust the dose and monitor INR. And this is should be done. The level should be drawn 4 hours after dose and trough just before next dose. It's available in our hospital, but it's underused. It's not requested frequently. I'm encouraging people to request, if there is the right clinical setting. And this is you should keep in mind if it is once daily or BID. If it's BID, you need to get the peak level 0.5 to 1. If it is once daily, it should be 1 to 1.5. And this is it's again the same. It is not right now the scope of this presentation, but this is it needs a presentation per se. And monitoring, and this is for different, low molecular heparins, but most of them, they will have the same 0.5 to 1 or 0.1 to 1.5. And this is just the pipeline for a new anticoagulant. Just a question for what will be the role of anticoagulation clinic after a new anticoagulant? I think we will still need, anticoagulation clinic or thrombosis clinic, because assess compliance, monitor progress, bleeding risk, determine duration of anticoagulation, may need to monitor renal function because they are renal excreted, bridging anticoagulation. And patients who are rock solid stable on warfarin shouldn't be switched to new anticoagulant. And this is the end of my talk. Okay. I hope it was interesting. Okay.
Thank you, Dr. Mohammed. Next. I would ask Dr. Mohammed Al-Tanir to join us, please.